Hello, welcome to today's lecture, Psychogenic Non-Epileptic Spells. I am going to be your speaker today. My name is Donna Avanecean. I am currently practicing as a nurse practitioner at the Epilepsy Center at Harvard Healthcare Ayers Neuroscience Institute. The objectives of today's lecture include 1, to identify differences between epilepsy and psychogenic non-epileptic seizures, 2, discuss the diagnostic workup of patients with suspected PNES, and 3, discuss the 3 phases of treatment. I'd like to first begin with a brief description of epilepsy, seizures, and how it affects and impacts our population in the United States. Now, historically, epilepsy has afflicted human beings since the dawn of our species and has been recognized since the earliest medical writings. And there are few medical conditions that have attracted so much attention and generated so much controversy as with epilepsy. In 2015, it was estimated that 1.2% of the U.S. population had active epilepsy, and those numbers continue to grow. It is estimated that approximately 3.4 million adults and 470,000 children have active epilepsy. The cumulative index from birth to about 20 years of age is 1%. And how this affects individuals is very dependent on age. So as we get older as a population, so does the cumulative index of individuals developing epilepsy. So at about age 75, it's about 3%. Now, generalized seizures will present during the first 5 years of life, whereas as with increasing age, you generally see either partial seizures or focal onset seizures. And approximately 10% of Americans will experience a single unprovoked seizure throughout their lifetime. I'd like to now turn our attention to the pathophysiology of seizures, because this is going to have a good background for you to understand when we start speaking about PNES and the neurobiological factors that are thought to cause those events. Now, seizures are transient episodes of abrupt and temporary alteration of cerebral function. They play a major role for ligand and voltage-gated channels in epileptogenesis. Both of these have been implicated in causing seizures, as well as both sodium and potassium channel subunits, as well as neurotransmitted gated channels, such as nicotinic and GABA, all of which are implicated not only in seizures, but in epilepsy. Now, what happens during a seizure is that it's a result from an imbalance between excitation and inhibition within the central nervous system. Seizures can also occur as a result of alterations in membrane potentials that predispose certain hyperactive and hypersensitive neurons to respond abnormally to any changes within the cellular environment. These hypersensitive neurons have lower thresholds for firing and can fire excessively, creating a focus for seizures. We'll now move our attention to the classification of seizures. Now, probably since I've been practicing in the field of neuroscience nursing, which dates back to 1979, there have been multiple renditions of how the International League for Epilepsy has re-identified seizures in many different ways. And so more recently, a newer classification came out. This is the basic version of it for the purpose of this lecture. This was revised in 2017, and again, this is from the International League Against Epilepsy. Now, what the new classification of seizures does is it breaks it down and simplifies seizure characterization or categories. So it breaks it down into focal onset, general onset, and unknown onset. And then when we talk about something being a focal onset, we're talking about a specific part of the brain where this abnormal firing of hypersensitive neurons is taking place. Now, focal onset seizures can be further divided between aware and impaired awareness, and further broken down into motor, non-motor as well. Now, also know that focal seizures, if they continue to recruit enough neurons, they can go on to develop, or the patient can go on to develop, a generalized tonic-clonic seizure. So usually in these cases, the patient or the seizure focus begins in one area of the brain, and it recruits enough neurons extending to the other hemisphere of the brain, thus causing a generalized tonic-clonic seizure. Now, with generalized onset, the implication here is that both hemispheres are involved, not just one, and not just one specific part of the brain. These are always going to be with impaired awareness because both hemispheres are affected. They can be further broken down into motor and non-motor, such as with the focal onset. Motor can include tonic-clonic, tonic, clonic, drop attacks, and in the non-motor, absence. And then unknown onset is usually an individual who probably does begin their seizures in a focal onset, but there is such rapid progression of the seizure activity that it is difficult to detect and actually presents as a generalized seizure. So very similar breakdown, both motor and non-motor, respectively. Now, the diagnosis of seizures and epilepsy is made through clinical history taking and neurological examination. When taking a detailed epilepsy history, you want to know the age of onset when the events first started, a very detailed description of what occurs before the seizure, during the seizure, and after the seizure. This is known as seizure semiology. And it's very important because this is probably the foundation to what is going to be built in trying to localize where these seizures are coming from. The next thing you're going to want to do when taking a detailed history regarding the seizures, in addition to what I've just said, is that you're going to want to know the duration of the events. You're going to want to know how long it takes for the individual after their seizure to recover back to their baseline, and then the frequency of seizures, and of course, what are some of the provoking factors that could initiate a seizure, such as alcohol intake, missing a dose of medication, not taking the medication on time, not getting enough sleep, stress. There's multitudes of provoking factors, bright lights. In addition to obtaining a thorough history regarding the seizures, you're going to want to identify any risk factors for epilepsy, such as complications during the pregnancy or birth or any developmental delay. So you want to know about growth and development of the patient as a child, whether or not they were or experienced any difficulties with their schooling, repeating grades, difficulty with specific subjects. Family history of epilepsy. We know that there is a genetic predisposition for epilepsy within families. History of CNS infections, encephalitis, meningitis. Of course, brain tumors or any other CNS mass. So maybe somebody with a history of an epidural or subdural hematoma, head trauma, and autoimmune disease. Of course, performing a neurological exam. In most cases, your neurological exam is not going to help with the diagnosis, but for detail, you need to perform one. Imaging studies, the most important is using an MRI. And if you are working in a facility that has the ability to perform an epilepsy protocol, you may want to order your MRI imaging, which, by the way, is without gadolinium, unless there's a strong sense that you may be dealing with some type of a malignant process within the central nervous system, in which case you would want to order the MRI with and without gadolinium. And of course, EEG. Now, there's 3 levels of EEG that you can potentially order. The first is a routine EEG, which takes approximately 30 to 45 minutes within an office setting. And the patient is usually provoked with hyperventilation and photic stimulation. The next type of EEG involves a take-home EEG, also known as an ambulatory EEG. And you can arrange for this or you can order this either as a 24, 48, or 72-hour EEG. And if there is capability from the family, you may want to also order that with a video. The patient comes into the office, the electrodes are placed, and depending upon what particular order you're writing for, whether it's 24 or 72, the patient then comes back and has the EEG's electrodes removed, and the EEG is downloaded into a system for the epileptologist to read and make a diagnosis. Medical management can be broken down into medications and surgery. Both will be reviewed very briefly during this lecture. So for medications, know that these are some general pharmacological pearls. Know that most AEDs are metabolized by the liver and excreted by the kidneys. The selection of anti-seizure medication is based on efficacy against a seizure type and potential side effects. Know that dose-related side effects are very common and usually will resolve spontaneously with either decreasing the dose of the ASM or withdrawing the medication altogether. Therapeutic ranges are necessary or good to obtain in the older ASMs, not so much with the newer ones. And the second time that I usually will order therapeutic ranges is if I think there are issues with the patient actually taking their medications. Most of the common symptoms, though, that you will hear about include GI upset, dizziness, nystagmus, dysarthria, diplopia, ataxia, and skin rashes. The 2 or 3 ASMs that are most a culprit and can lead to serious conditions include Keppra, as well as lamotrigine, phenytoin, and there is a cross-sensitivity between phenytoin and carbamazepine, which can, the rash can develop into a Stevens-Johnson syndrome. Keppra can lead to DRESS syndrome. Now, the good, the bad, and the ugly of the older agents. So the older agents, such as carbamazepine, also known as Tegretol, phenytoin, also known as Dilantin, valproic acid, also known as Depakote, and then phenobarbital. These are excellent agents. They're still used, but they do carry a lot of problems and issues for not just the providers, but more importantly for the patients. And the reason is that the older agents are all highly protein bound. And so what happens is that, especially with phenytoin, a lot of drug-drug interactions, and I would say the same for Depakote. So you have to be very careful when you're using these medications, even within ASM to ASM. So if you started, let's say, phenytoin and Depakote, you do have to realize in the dosing that one might increase the dose of the other, making the other medication more bioavailable for seizure prevention. Most of the older ASMs had a shorter half-life, and this leads to multiple frequent dosing. And this is where compliance issues really become an issue, because now they have to remember to take something 3 times a day or 4 times a day. Instead of with the newer agents, they may only have to take it once a day. Multiple adverse reactions. The biggest one that you have to be concerned about is the induction of liver enzymes. Now, the older agents, such as valproic acid, are either barbiturates or they fall into a sodium channel blocker category. Phenytoin and carbamazepine are both sodium channel blockers. Now, the interesting thing about valproic acid, this is the drug that you love to hate. And the reason being is that side effect profile is not great. And it has a black box warning of liver failure. But the good thing about valproic acid is that it does have a neurotransmitter effect, specifically on GABA. And this is actually what spurred the development for the newer AEDs, because it then allowed or opened the door for people to have an understanding of how these medications work on GABA and how GABA is implicated in its role with seizures. The last big point that I want to make about the older agents is that it does require frequent lab monitoring, not because you're checking for therapeutic ranges, but because these agents can lead to other lab discrepancies, such as white blood cell, a decrease in the white blood cell count. So carbamazepine is known to cause anaplastic anemia. Thrombocytopenia. Depakote not only causes thrombocytopenia, but can also cause the platelets to be inefficient in the job that they are doing. And finally, carbamazepine can lead to hyponatremia. So it did require providers who were using this drug to closely monitor the medications and the side effects. Now, the newer AEDs, probably starting from gabapentin, lamotrigine, and of course, the one drug that really changed how we treat epilepsy in the acute stage in the hospital, Keppra, and there are many more newer agents that have now entered into the market. They are ideal for many reasons. Now, do they cause side effects? Yes. Do they make people feel crummy? Yes, but less crummy and less side effect profile. They have a very different mechanism of action. So now they are either going to be working directly at the cellular level, or they're going to be working towards moderating and mediating neurotransmitters. They're more oral available. They have either a no to low protein binding. Medications such as phenytoin are very dependent on protein and are very protein bound drugs. So if you have somebody who has a low protein level, you need to then adjust their phenytoin dosages, because there's not going to be enough protein molecules for the phenytoin to attach to, thus causing a super therapeutic phenytoin level. The newer agents have longer half-life, so now you're either going to be doing a daily dosing or a Q12-hour dosing. Linear kinetics, making the dosing easier. phenytoin, great drug, but one of the problems is it has a non-linear kinetics, meaning that increasing the dose just a little can yield a very, very high amount of the drug in the person's system. And so, they can be going along with monitoring their serum concentration levels, and you're increasing the dose, they're doing great. And then all of a sudden, they go from a lab that is within range and good therapeutic control of the seizures to now a super therapeutic drug level with the patient now experiencing side effects. The newer agents do not have any active metabolites. There's no liver enzyme induction. And as I said before, the side effect profile is very low. It is not none, but it is much better than with the older agents. The treatment objectives when you are medicating somebody for their epilepsy is to control the seizures while minimizing side effects of medications. Otherwise, I can tell you, compliance with these medications goes from 10 to 0 in a very short span of time. So the treatment objectives is to manage the seizures while not inducing side effects. The majority of the anti-seizure medication side effects will include somnolence, dizziness, and brain fog. The newer agents, though, as I've mentioned before, do not require therapeutic drug monitoring. And really, when you're approaching treatment options for your patients with epilepsy, your goal is for monotherapy. And it's important to include the patient in these discussions about what their goals are. I mean, are they happy with just one seizure every 6 months? Because for many of these patients, you're never going to get down to 0 or no seizures. In a small population, you will see patients who are at a very low dose for many years of one of the older ASMs and have been seizure-free for 20 or 30 years. But again, the goal is always for monotherapy, because we know from research studies that adding a second or third ASM is really only going to yield approximately 85% seizure reduction. So it's not 100%. So, you don't make yourself feel or the patient feel any better by adding a second agent. If you have to, then of course you do. But you do need to start being careful about not giving or not prescribing a medication, 2 seizure medications that are from the same family. Like you would never give someone, let's say, oxcarbazine, which is a sodium channel blocker, the other name for that is trileptal, and then add lamotrigine, because both are sodium channel blockers, and they may actually not work well together. So you try to, if you do have to add a second agent, to add a second agent that is from a different pharmacological family. Now, I mentioned that the second part of medical management is actually surgical management of patients with epilepsy. We can offer surgical treatment for both focal and generalized and even unknown, or I should say idiopathic epilepsy. It's just going to depend upon what types of surgery we can offer. So for those patients that have focal aware or focal unaware seizures or focal seizures, and we know where the seizure focus is, there is the ability to do what's known as a resective surgery, where they actually go in and take that part of the brain that is causing the seizure activity. Now, of course, the caveat to this is that the focal area cannot be in a eloquent brain area, meaning a speech area or right on top of a motor area. So there's a lot of workup that is required in order to determine whether or not someone is a candidate for resective surgery. Now, for those patients who we are not able to identify a focal onset area, we can offer them modulation therapy, and this can be accomplished either through a vagal nerve stimulator, an RNS, or a DBS known as deep brain stimulation. Now, the remainder of this lecture is going to be focused on our discussion about psychogenic non-epileptic seizures and what you need to know. Now, the reason why I started the lecture with a brief description of epilepsy and how we treat it is because patients who have epilepsy can also have psychogenic non-epileptic seizures. So that's the reason why I started off with the explanation of seizures and how we treat them. But now the remainder of the lecture, as I've said, will be focused on diagnosing of psychogenic non-epileptic seizures and how do we treat them. So let's start off by talking about what it is and what it is not. I want to first say what it is not. It is not faking. These are not pseudo seizures. The individual does not have any ability to control these events any more or any less than they can control their epileptic seizures. Now, what it is, though, is PNES is one of the 4 types of functional neurological disorders. So they can be broken up into functional movement disorders, functional seizures, as I've mentioned, persistent perceptual postural dizziness, and functional cognitive disorders. Now, all FNDs are different in how they present and features, but they do share one common pathway. And what that pathway is, and what they've been able to identify, is that there is an overactivity of the limbic system and a dysfunctional brain network, which is responsible for giving movement the sense of voluntariness. Okay, so they have been able to decide where or determine where in the brain is this all stemming from. Now, there are various networks within our brain. So in the yellow areas, this refers to the hippocampal diencephalic and parahippocampal retrosplenial network. So what's that? It's a mouthful. So what's their responsibility? So their function is for memory and spatial orientation. When these areas are affected, you can have amnesia, you can develop Korsakoff's syndrome, which usually is commonly seen with patients with high intake of alcohol. Mild cognitive impairment is associated with breakdown in these networks, Alzheimer's disease in its earliest stages, and Balint syndrome. The second network is the temporal amygdala orbital frontal network. Now, this network is responsible for behavioral inhibition, memory for temporary complex visual information, olfactory and gustatory visceral functions, multimodal sensory integration, object reward association learning, and outcome monitoring. When these areas are affected, we think of things such as more advanced Alzheimer's disease, semantic dementia, Kluver-Bucy syndrome, temporal lobe epilepsy, Gershwin syndrome, psychopathy, bipolar affective disorders. So this is the area that's involved with all of these disorders. And then finally, the areas in blue are the dorsomedial default network. Their main function is pain perception, self-knowledge, attention, mentalizing, empathy, response selection and action monitoring, autobiographical memory, and person perception. When these areas are affected, They can lead to depression, autism, schizophrenia, obsessive compulsive disorder, mild cognitive impairment, early stage Alzheimer's disease, attention deficit hyperactivity disorder, and finally, anxiety. So anxiety, all those areas are the area or the network that's involved is the medial default network. Now, let's look at some definitions of PNES, because it's not so much the definitions that are causing a lot of controversy, is the wording of how, or the naming of how we should call this. And this is spurring a lot of discussions. I know we in my department discuss this all the time about, so how do we label these? What should we be calling them? I don't like to call them non-epileptic seizures, because then for some patients, it's very hard for them to understand. I like the psychogenic non-epileptic spells, only because I think it better describes what they are. They're spells, they're episodes. But by definition, they are paroxysmal events that are inclusive of both minor and major movements or lapses in attention and consciousness that is not an outcome of an epileptic disorder. Now, that's a very fancy way of saying that we're seeing motor signs, but without an EEG correlation. Okay, so there's an event, but no EEG pattern changes. The differential diagnosis includes epilepsy, because sometimes you get fooled. You'll think somebody has non-epileptic spells, and then when you do this detailed investigation, you only come to find out that those actual spells are really epileptic seizures. And that has to do with, well, not just the location, but when people are describing what's happening, sometimes if you're not understanding clearly those networks that I just went over, you may miss something. And so you may not have an understanding like, oh, yes, if the patient is coming in and they are smelling something bad, or they're feeling upset in their stomach, that must be coming from the temporal lobe. And now you're going to think, well, no, that they must not be having epileptic seizures. They must be having non-epileptic spells. Movement disorders. You want to also rule out that the person is not suffering from a movement disorder. And then the most common one that sort of coincides and needs to get differentiated is syncope, because there are syncopal seizures. When we know that blood pressures go down, heart rates go down, patients can have a syncopal seizure. So you have to keep that in the back of your mind. So what do these events look like? What does a non-epileptic spell look like? Well, this can prove to be very challenging, but many epileptic seizures can present with atypical symptoms such as feeling anxious, nauseous, retching, all symbolizing frontal lobe seizures. So it's really important that you have an understanding of the functions of the different parts of the brain. And because this is going to help you try to decide, well, could this be? I mean, this person's coming in and all they're saying, we recently had somebody in our unit and her entire seizure was this anxiety feeling. And all she was able to tell us during these events is, I feel nervous, I feel nervous. That was it. And she, in fact, has frontal lobe seizures. Rather deep, but she does have them. Common signs, though, that would make you think that this is a PNES picture include asynchronous limb movements. So maybe an arm, then a leg, then an arm, then a leg, then one side, then the other side. That doesn't make any sense from an anatomical perspective. Out of phase clonic activity, intermittent shaking with periods of inactivity. We had a young girl recently that was admitted, and her events went on for hours and hours. We knew already that these were non-epileptic events, so we ruled out the possibility of her being in status epilepticus. Obviously, we wouldn't have not treated her. So in this instance, this individual had long periods of intermittent shaking and then not being responsive and then going back to shaking. Pelvic thrusting or pelvic movements, dystonic body posturing. And in general, the eyes are going to be closed during the event. For most folks, if they are having epileptic seizures, the eyes are going to be open. They are going to be deviated away from the seizure, because the seizure, let's say if the seizure is occurring in my left side of my brain, that's the irritant, the left side of my brain. So the eye deviation will be towards the right, to the opposite side. Okay. Now, unfortunately, I'd like to say that all of this is pathogenomic, but they're not. It's not, there's nothing written in stone here that says for sure if you have all of this, they have to be PNES, because every time you say that, you may be fooled. So what could differentiate the two? Well, in general, patients with epilepsy and who have epileptic seizures, they usually will sustain significant injuries such as soft tissue injury, urinary incontinence, fractures, common especially in generalized tonic-clonic seizures, shoulder fractures, shoulder dislocations, head injury. However, not all patients with epilepsy will sustain injuries. This is going to depend upon the location of the seizure origin. Diagnosis, well, historically, it's been one of exclusion. But now the current thinking is that you have to rule it in. So while simultaneously you're ruling in whether or not this could be an epileptic seizure, you're also trying to rule in whether or not there's going to be other diagnoses that are causing these symptoms. Optimal testing for the diagnosis is admission to epilepsy monitoring unit for a video EEG. And that is the best way to diagnose these patients. Let's turn our attention now to the epidemiology. How many people are really affected by this? Well, the data sources are very scarce and limited. However, it is a relatively very common disorder seen in epilepsy clinics, and account for about 20 to 40% of all admissions to the epilepsy monitoring unit, including the one that I work in. Reports demonstrate that PNES patients can account for about 5 to 10% of all clinic visits. The incidence of PNES in those studies that have been looked at is estimated to be about 1.4 to 4.9 cases per 100,000 individuals per year. And the prevalence of individuals with PNES is anywhere between 1 in 50 and 1 in 3,000, or 2 to 33 cases per 100,000. And I stand corrected, that's 1 in 50,000 in the population. PNES tends to be seen in all ages, but can begin in young adulthood. And unfortunately, there's usually a delay in proper treatment. Some patients are treated for years for epilepsy, leading to unnecessary treatment and potential harm from these seizure medications. Patients presenting to the ED can receive very high doses of rescue medications such as midazolam, Valium, lorazepam, leading to intubation and placement on mechanical ventilation. We do know that PNES tends to affect more women than men. And it can occur in about 5 to 50% of all patients who have epilepsy. Also suffer from PNES. So something else to think about. Usually occurs in a heterogeneous patient population. Most common factors include sexual abuse, a history of physical abuse, emotional abuse, traumatic brain injury, neglect as a child, medical and psychiatric comorbidities. Much of the trauma can occur in childhood, but I've also seen this happen when, childhood has been fine. They've unfortunately been raped in either college or later on. We recently had someone who was a newlywed only to be raped by a neighbor that was close by. Any perceived trauma really can lead to these. There are studies now looking at specific markers determining if there are certain social factors or psychological factors that puts an individual at a greater risk for developing PNES. Also know that PNES is hard to treat. It can occur for months to years after the abuse. Now, I mentioned before about talking about the pathophysiology of epilepsy and said that this would be important because I'd be talking about some of the neurobiologic origins of PNES. Well, even though we know that there is some neurobiological origin, it's still very poorly understood. But what studies have demonstrated is that there are neurobiological mechanisms that occur in patients with PNES that are very different from those in epilepsy. And there was a study conducted on both healthy controls and those patients with diagnosed and confirmed PNES, using a functional MRI. I think it was a 7T. There was 17 PNES patients and there was 20 healthy controls. And they did the MRIs on both of these individuals. And what they found in the PNES population was that they had altered functional and structural networks within their brain. So all those networks that I was talking about within the hippocampus and such, theirs was altered. And that's what's they're thinking. The hypothesis is that this is some of the origins of what leads to, because many people sustain trauma within their lifetimes. And some people are able to, I don't want to use the word move on, but they get into the bright therapy. They were amenable to the therapy. They realize that this was a terrible thing that happened in their lives, but they are still able to move beyond it. And what is it about the PNES patients that they can't? It's not that they don't want to. Many of them do want to get better. Now, is there a certain population that doesn't? Yes, but I would say the majority of them, I believe, truly do want to get better. Now, the hypothesis behind all of this is that there is a suggestion of an alteration in the influence and connection of brain areas which are involved in emotion processing onto other brain areas responsible for sensory, motor, and cognitive processes. So again, go back when you're going over this talk, go back to that slide regarding those networks. And what else has been conceptualized is that these are brief episodes facilitated by a very unstable cognitive emotional attention system. So what does this all mean? Well, PNES could be the result of a neurobiological dysfunction of specific brain networks and abnormal connectivity of those networks. Treatment. There are a lot of treatments out there, but the one thing we do know is that this is a multimodal approach. It's going to take a psychiatrist, it's going to probably take a therapist, the neurologist, and even a social worker who specializes in these types of patients. Many of these patients who have been misdiagnosed with epilepsy may be on multiple anti-seizure medications, in which case you would want them to be discontinued. Now, here's the caveat to this one, or pearl. There are some patients that will tell you, you know, I had less events when I was on lamotrigine. Now, you can keep the lamotrigine because the lamotrigine is also used for mood stabilization. The only thing that I would caution you is if you do that, is to really explain to the patient, you know, I'm not surprised that it is helping you, because this medication specifically is really good for treating patients with emotional lability. And so I'm quite sure that it did help, and you can continue them on it. Otherwise, it's going to be the neurology provider that is going to slowly start to remove the anti-seizure medication while the patient is going through their therapies. Workup. Well, as with the patients with epileptogenic seizures, you want to take a careful history. You want to ask all those key questions. So the history taking, the risk factors for both epilepsy and PNES. It's pretty much similar to what we did with the epilepsy patients: routine EEG, ambulatory EEG, and of course, like I've stated before, the gold standard would be to admit them to an epilepsy monitoring unit, whereby we can see their EEG tracing while they're having the seizure, which is being video recorded. Usually when these patients are admitted to the epilepsy monitoring unit, there's withdrawal of the ASM medications 48 hours prior to the admission. And what the EMU admission allows, of course, I've just mentioned it, is the continuous EEG monitoring while the recording occurs for the events. Patients with PNES, as I've mentioned before, will have an event with no EEG correlate, and this allows us then to confirm the diagnosis. Now, another pearl. The individual who is laying in that epilepsy monitoring unit being monitored cannot, in their normal state, have any evidence of any epileptogenic foci noted on their EEG. They have to have a normal background. They have to have no evidence of any epileptogenic foci or things like spike in waveforms. All of that, they must have a squeaky clean EEG. Now, some of them, will come in with prior, with drug use, and you may see some background slowing on their EEG tracing. But most times that's most likely due to their drug or alcohol intake. We've had patients come to our unit who have been, drunk. They actually took their last drink prior to coming in, knowing that they weren't going to be able to drink while they were in the hospital. Giving the diagnosis, this is probably one of the most difficult, because remember, these patients, a lot of them have a lot at stake because of their presumptive diagnosis of epilepsy. We had a young lady not too long ago that, we're telling her this is great news, you don't have epilepsy. But for her, it wasn't great news, because we later found out, she told us that when the group home that she was living in, she had a lot of psychiatric issues and couldn't be handled at home, that there was another young client there who had epilepsy, and she noticed that that person always got a lot of attention and people were kind to her because of her epilepsy. And so she began to have events in order to get some attention. And she said that when everyone thought she had seizures, they didn't treat her like crap, which is very heartbreaking to hear. Nonetheless, we confirmed her PNES, and it did not go well. And it led to her, unfortunately, having an involuntary commitment to our one of our psychiatric units. So the diagnosis, once we confirm it, the conversation must take place before discharge. We do not leave it up to the other physician that sent the patient to us. How you communicate, your body language, the tone of your voice, cannot be stressed enough. All of this, you have to really keep it in such a neutral tone. And it's a three-phase approach. So the initial phase is communicating with the patient and, if possible, their family, stressing to the family that the patient is not responsible for these events. The communication is usually done by the neurologist. It's usually our responsibility. And again, I know I keep mentioning this, but how we do it, it has to be given time. They need time to absorb what is being said to them. The thing that I always stress with new clinicians is not to blame the patient. And I always tell them, you are not at fault. You have no control over these. You have gone through so much in your lifetime, and this is your only, this is the only way that your body is now able to handle this amount of stress. And usually when you put it into that context, it is not greatly received, but it is received much better. The second phase of treatment is engagement. So if the patient doesn't already engage in psychotherapy, we need to first get their willingness. And this is not a quick fix. It can take many months to years of treatment. Many do not want to face the reasons that led to them experiencing PNES, so prior trauma, prior rape, things like that. By the end of phase 2, the patient should have an understanding of their diagnosis and do not seek workup elsewhere. It is not uncommon for patients to go from one epilepsy center to another epilepsy center with the hope that the results are going to be different. And if not already done, you want to get them established with a psychotherapist. In phase 3, a formal psychiatric assessment should be arranged. Individualized psychotherapeutic and psychopharmacological treatment plans should be formulated. And the goal in phase 3 is to decrease the events, which can take many months to years to be successful. The primary therapy that is used is cognitive behavioral therapy. And other theories that have been used and studied that were met with less effectiveness included psychodynamic therapy, family therapy, all of which did not prove very fruitful. In phase 3, we recommend discontinuing of the anti-seizure medications, unless, as I said before, the patient is finding some benefit from it. So many of the ASMs, especially Depakote, gabapentin, and lamotrigine, can be continued because they are used for mood stabilization. If continued on these agents, we can stress their use in the patient. Patients with mixed epilepsy and PNES will be required to continue whichever ASM they are currently on. And patients with mixed epilepsy and PNES will need to also have careful documentation of their various seizure types, and then possible treatment. Prognosis. There was a systematic review that was performed, I believe, in 2021 that demonstrated 40% of adults with the diagnosis, confirmed diagnosis of PNES, became seizure-free within 5 years. There are other studies that are currently looking, as I've mentioned before, at the psychological profiles to determine which patients not only will be more susceptible to having them, but will be more apt to improve with the cognitive behavioral therapy. But overall, you should come away with the knowledge that the prognosis for these patients is fair to poor, which is very unfortunate. One additional thought, what to name these events. So as I alluded to before, there is a lot of discussion going on in various centers, including mine, about how we are going to label these patients. Because again, I don't like the pseudo seizures, and I don't like using the word seizures. So I'm hoping that when we do finally come to a conclusion in my area, that the word spells is going to be included in whatever else we identify these as. This concludes my presentation. Again, I hope you found this very helpful and enjoyable. If you have any questions, please feel free to reach out to me. And I thank you today for your attention.